Okay, our topic for today is HELP syndrome, and the other topics for this week's lecture on NCM 109. So let me just flash my screen. We'll have first HELP syndrome. Okay, so this starts for your hemolysis, and then you have your elevated liver enzymes and low platelets with a pregnant woman suffering from hypertension. But let us focus on what are the things that the book is telling us, that this hemolysis really leads to anemia, and elevated liver enzymes will let the patient to feel epigastric pain, and these low platelets lead to blooding or clotting. So for this one, it could be a factor that is causing maternal morbidity and mortality, and of course, the mortality and morbidity of the infant. But again, the cause is unknown. And the things that are predisposes us to have this one are your being a primigravida and a multigravida as well. So before, it is just for primigravida, but now the updated version of the book says even the multigravida have the possibility of having the disease. And the association of HELP syndrome to hypertension is well known, but we have here the APS or the antiphospholipid syndrome. And this antiphospholipid syndrome is an autoimmune disease. Actually, let me just annotate. It is what we call as the sticky blood syndrome. Sticky blood syndrome, that there is a problem with coagulation. It is an autoimmune disorder, or what we call as the Hoag-Hess syndrome. So this one is new. It causes pregnancy problems, and of course, it could also cause miscarriages, and now a factor that is causing both HELP syndrome and hypertensive disorders in pregnancy. And when you have this APS or APAS or the antiphospholipid antibody syndrome, you are prone to develop your DVT, what else? Your blood clots in the brain, the stroke, and of course, multiple sclerosis. But we will not dig deeper to what is your APS. But again, you have to take note that this is, again, your APS is called as your sticky blood syndrome or your Hoag-Hess syndrome, which is an autoimmune disease with a problem on coagulation. Next. Okay. So for the signs and symptoms, as you noticed in the presentation, there are now additional signs and symptoms from that of the hypertension. In your hypertensive disorders in pregnancy, you have noted your hypertension, edema, and proteinuria as a triad symptoms of the disease, but now you have your nausea with the epigastric pain because of the problems in the liver, and these elevated liver enzymes will also cause the right upper quadrant tenderness and liver inflammation. Okay, it also causes this also causes your thrombocytopenia because this is related to your hypertension. What happens in hypertension is there is vasospasm. So when there is vasospasm, the epithelium of the vein, okay, or the blood vessels in your body is not good. So what will happen there? According to the book, the platelets will just be staying in one place, and then when you get the platelets in the body, it will be very low. So that is now the thrombocytopenia related to hypertension. Okay. So what are the complications? So your complications are, as you see, you have a liver hematoma because there is a problem with the SGPT and SGOT and this hyponatremia and renal failure. Of course, you have your hypoglycemia because you have a problem with the liver and the cerebral hemorrhages, aspiration pneumonia, hypoxic encephalopathy, fetal growth restriction, and a preterm birth. Okay. So these are just the known complications of the disease. So what will we do since we have a problem with the platelet? The patient might need what? The patient might need a fresh frozen plasma. And because the patient is having hypoglycemia, okay, because of liver problems, the patient might need IV glucose infusion. And since we are having a problem on this signs and symptoms, the patient might be wanting to deliver via NSD or CS, but sometimes we prioritize having the CS delivery. And epidural anesthesia should not be given this time because it could lead to hypotension. And patient will need reassurance that symptoms are pregnancy related and will not return. So HELP syndrome, or the symptoms that the patient feels in HELP syndrome, will just be there during the pregnancy. But then again, you have to tell the mother that since she had the syndrome already, and there's a possibility that she will have it again. Okay? What matters most is you have explained to her that after the pregnancy, the syndrome will be gone. But then again, if she will get pregnant again, it may return. Okay? So that's how you explain to the patient. So this one, so that's the HELP syndrome. We'll have multiple pregnancy. Multiple pregnancy, as what I mentioned to you in the previous lecture, it is now a complication of pregnancy because the body could just adjust in one fetus. And sometimes this multiple pregnancy occurs in because of in vitro fertilization, not only in vitro fertilization, but your gamete intrafallopian transfer. And this could be the possible reasons of a multiple gestation. Okay, so we have here the first type, we have the identical or monozygotic twinning. As you see, it come from a one zygote, okay? And then it splits into genetically identical twins, and they have a sharing of placenta. So in here, let me just annotate. I'm sorry, I have to click so many things before I can annotate this. So they are sharing one placenta. They are sharing one placenta. They have two umbilical cords. They have two amnion. They have two amnion, but they have one chorion. So it is 1, 1, 2, 2. So one placenta, you have your one chorion, two amnion, and two umbilical cords. For the identical or monozygotic twinning, it's 1, 1, 2, 2. Again, 1, 1, 2, 2. We have one placenta. We have one chorion, we have two umbilical cords, and we have two amnions. Okay, we have two amnions. Next is, okay, for this one, they are usually have the same sex, okay, and they occur or they account in 1/3 of twin births. So again, it's 1, 1, 2, 2, one placenta, one chorion, two amnions, and two umbilical cords. For the dizygotic fraternal non-identical twins, okay, so you have two zygotes here. You have two zygotes here. They are genetically distinct, but they have separate placentas. In here, you have two, two, 2, 2, 2, 2. Okay, so what is that? Four twos. They have separate placentas. They have separate placentas. They have two umbilical cords, and they have the two amnions, and of course, they also have the two chorions. Okay, so they have two placenta, two umbilical cords, two amnions, and two chorions for the dizygotic fraternal non-identical twins. Okay, so what is now the update in here? Okay, how do we update this one? For the dizygotic non-identical fraternal twinning, the book is saying that it could be coming from two different sexual partners, okay? Or they may have the same or different sex. So they have, what you have to understand is they could be coming from two different fathers, and they have or may not have the same sex. So they have the two placenta, two amnion, two chorion, and two umbilical cord for the dizygotic twinning. We also have octuplets, and this octuplets are again sometimes from in vitro fertilization or from inheritance. Okay, from inheritance. Okay, it may be from inheritance or from in vitro fertilization. But then again, this one, there are chances that they may die because according to the book, only 30% of them or one fetus will remain. So this one, you have to note that the AFP is elevated. When we say the AFP is elevated, there might be a chance that the fetus or the fetuses inside might have what? Anencephaly and spina bifida, right? Anencephaly, and spina bifida. When the alpha fetoprotein test is elevated, the patient or the babies might have anencephaly and spina bifida. But if the AFP is low, I will just have to write it here, but this is not already related to twinning. But if the AFP is low, it might be because of mental retardation. It might be because of mental retardation or trisomy 21, okay? Or trisomy 21, right? Or trisomy 21. So we have here for twinning, the AFP is elevated. Bakit namamatay yung bata? will these fetuses will die because of anencephaly and spina bifida because their AFP is elevated. And as you see in twinning, because they have um, or there may be few numbers of fetuses inside the mother's womb. You see the increased size of the uterus that might lead to preterm labor. And of course, the quickening is not in one spot. There are many spots where you can find quickening. And of course, a multiple set of fetal heart tones. And again, the mother may grieve because the mother may maybe losing some of the babies and one may possibly survive the multiple gestation. Okay, for the therapeutic management, okay, let me just clear all my drawings. They are the most susceptible to complications since multiple gestation is a complication of pregnancy. It is expected, therefore, that the mother will have so many complications. They may be prone to develop hypertension, polyhydramnios, placenta previa, preterm labor, anemia, and of course, because you are carrying one more fetus or more than one fetus. And the mother may be prone to postpartum bleeding. Why? Because of the overstretching of the uterus, and because the uterus is not that big, okay, the baby may be low birth weight, okay. Then you have to, for this one, there are cases wherein the amnion is also present and there is a knotting and twisting of the umbilical cord. If, for example, the twinning will have one amnion. There are cases wherein we have twins that they have or they share one amnion. So what will happen to their cord? They will have twisting. So we have to have a closer monitoring for this one. Okay? Next is polyhydramnios. In polyhydramnios, you have noted that this one is because of an abnormal amniotic fluid greater than the normal. Your amniotic fluid may be 1,000 to 1,200 ml. And if it's more than that, you see the baby is lying in a pool of amniotic fluid that is more than 2,000 ml, and the fundic index, okay, or the fundic height is more than 24 centimeters. Okay, it could cause malpresentation of the fetus. Why? The fetus could move transverse or longitudinal or in an oblique line because of the permission of the amniotic fluid. Okay, and of course, it could lead to a premature rupture of membranes. Why? Again, this is applicable with this is true with the theory of uterine stretch theory. In uterine stretch theory, what do we say in uterine stretch theory? What do we say in uterine stretch theory? The theory is saying that any hollow muscular organ, any hollow muscular organ, any hollow muscular organ, when stretched, okay, when stretched to capacity, when stretched to capacity, will contract and empty. Okay, will contract and empty. So when the uterus is stretched, okay, a very very a stretch and a very very big, or if it's highly stretched because of the amniotic fluid is more than the normal, then it could contract and release the baby. And of course, it could lead to a prolapse cord and preterm birth because of premature uterine contractions. Okay. Next is we have, actually these topics are not so difficult. Before, polyhydramnios is also called as hydramnios, okay? Polyhydramnios is also called as hydramnios. Before, polyhydramnios is just because of tracheoesophageal fistula, but the book is now saying that polyhydramnios might be because of excessive urine production, okay? Excessive urine production, or what would lead to tracheoesophageal fistula is being if the fetus is having an anencephaly. So if the fetus is having an anencephaly, generally the alpha fetoprotein test is high or abnormally high. So here, there is also the possibility that there is a hyperglycemia of the fetus, and because the amniotic fluid is so is above normal, it could be very hard for the nurse or the doctor to palpate the fetal parts. Of course, it will be very difficult for them to know where is the fetal heart rate, fetal heart tone or the fetal heart rate. And the mother might be suffering from shortness of breath because of the pressure of the what? Of the gravid uterus. And aside from that, because of the pressure of the gravid uterus, they will have what? Varicosities and hemorrhoids later on. And increase in a weight gain, okay? Beyond what is normal. So that is your polyhydramnios. What will we do? it's okay that the patient will go home, but you have to tell the patient to see if there is rupture of membranes, to differentiate what is coming out, if it is the amniotic fluid or the urine, so we could bring the patient into the hospital. They may need high fiber diets because they are not allowed to bear down. When they bear down, it might cause preterm labor. And of course, if possible, they may do amniocentesis. Okay, when you say amniocentesis, they will be extracting some of the amniotic fluid to at least save the pregnancy and make the size of the uterus normal. And tocolytics are given. What are again your tocolytics? They stop preterm labor. You have your ritodrine, you have your terbutaline, and you have your before magnesium sulfate, but magnesium sulfate is no longer included. So you have your ritodrine as the safest tocolytic. When you say tocolytic, it stops preterm labor. Again, your terbutaline, the side effect of terbutaline is tachycardia. So you have to detect or check first the heart rate before giving terbutaline. But terbutaline should not be given for more than 72 hours because it could lead to cardiac arrest. And of course, if there is cord prolapse, uh, meaning they could do amniotomy, and of course, the infant must be assessed with the presence of gastrointestinal blockage because the tracheoesophageal fistula that is present in there might be related to another complication in pregnancy or a complication of the fetus. So those are your topics. You have HELP syndrome, you have your multiple gestation, and you have your polyhydramnios. Okay, in your HELP syndrome, do not forget that it is more than the signs and symptoms of the HELP syndrome is more than the signs and symptoms of the hypertensive disorders in pregnancy. Okay, and in your what will you have to remember with this one? Okay, the cause is unknown and it is related also to APAS. And for your multiple gestation, do not forget the monozygotic 1122 and the dizygotic as 222. And the dizygotic could be coming from two different fathers. And twinning or multiple gestation is a complication of pregnancy that again might be coming from in vitro fertilization or what we call as inheritance or from the genes of the family. And then of course for polyhydramnios, do not forget that it could now be coming from two different reasons. Polyhydramnios could be coming from tracheoesophageal fistula, okay, tracheoesophageal fistula or excessive urine production. Okay, that will be all for today, and I'll see you in class. Okay.